Third Wednesday of the month. We're here at noon here at the beautiful Newhall Station for KHTS, your hometown station, coming to you on 1220 AM, 98.1 FM. You can catch us on the KHTS app, available for your iPhone as well as for your Android. That way you can actually pick up the show regardless of where you are, not only in the city, but also in California as well as the world. So you're joining us on the Providence Holy Cross Health Hour. My name is Tom Burton. I'll be the host for today, the orthopedic program manager at Holy Cross. And what an amazing May so far. It has been unbelievably busy in the Holy Cross house. And, you know, it's odd to think that Holy Cross is actually here in Santa Clarita, but with 30% of our patients coming from Santa Clarita, more than 30% of our staff who live in Santa Clarita, it only stands to reason that, being adjacent to the Santa Clarita Valley, Holy Cross is becoming a very, very important part of all of our lives. And it can be really witnessed as Holy Cross slowly starts to show new clinics and buildings here in Santa Clarita to try to be able to bring the best in health to the Santa Clarita Valley and the San Fernando Valley, as opposed to having to leave the valley or valleys in order to get that same care. So what's been going on? It's May. We've witnessed that Holy Cross, the foundation, SEV, Providence and the SEV, had an amazing event at the beginning of the month where we had the opportunity to take a look at our NICU and our needs in the hope to be able to add a bunch of new beds because, we birth children at Holy Cross like nobody's business. And, occasionally some of those children are in need for additional intervention. And years ago, before we had a NICU, a lot of those patients had to be sent to Valley Presbyterian or to other institutions, separating the baby from their moms. And so we felt that not only having the NICU, that'll allow us to keep our families together, but it has gotten to be so busy where we can't always meet that need, so adding beds is going to be important. So that was a big deal. The Pancreatics, led by our team captain, Dr. Bobby Igbalier, saw a great time Saturday, May 5th in the Purple Stride fundraiser for Pancreatic Cancer Action Network. Dr. Igbalier, I believe our team came in second in fundraising. I want to say we raised well over $20,000 in donations, which was great, towards their goal within the next few years to be able to double the life expectancy of patients who are dealing with pancreatic cancer. So, it's a lot about getting out into the community, kind of spreading the word, and trying to get people rallied up and excited to be able to get involved. And we love that. And as Dr. Igbalier said once on a show a bunch of months ago, he said, listen, give a call. Take a tour of the hospital. Take an opportunity to actually allow us to strut our stuff so that you can actually see how amazing work is going on. So, we introduced the birthday of Providence, Sisters of Providence, celebrating their 175th birthday. And I checked over at Hallmark. I'm not exactly sure what birthday that is. Holy Cross hosted 28 sports medicine students from Japan, from Chukyo University. Now, the important thing about Chukyo University is their sports medicine program is going to be one of the main suppliers of sports medicine when the Olympics are there coming up in the near future. So it was great to have them come in. America's 100 best hospitals by health grades, top nurse employer for California, 150 great places to work in healthcare. Our total joint program is the center of excellence with Blue Cross and Cigna. It goes on, the accolades. And recently being magnet certified, not for the first time, not for the second, but I believe for the third time, which indicates that our nursing staff is so well-trained and so well-educated, and that the care that's being given, evidence-based, research-based care, that our patients are getting top-notch care from our nurses as well as from the rest of the staff, which is extremely exciting. And for those who know about Joint Commission, we just had the pleasure of hosting Joint Commission. And when I say pleasure, that's probably on the line of a colonoscopy would be my guess. But the pleasure of having Joint Commission come in and take a look at how we are caring for our patients, as well as with Medicare coming in. So it was a big 5-day deal of having everyone, looking underneath the rug, so to speak. And boy, everything seemed to go pretty well. And maybe one of our guests will be able to discuss how all of that went, which I'm pretty darned excited. And I think we're going to go ahead and kick into this now. We have a very interesting group of people here today coming from Holy Cross. We've got Dr. Bob Raji, our Chief Medical Officer, Ken Archulette, our Manager for Infection Prevention, and Daniel Salas, who is the Antimicrobial Stewardship Manager. And, it's great to have a variety of different areas being represented: physicians, nursing, physical therapy, pharmacy, things like that. So I cannot tell you how excited I am to be able to talk about today, because we're actually talking about something that's really important, something that Joint Commission was really taking a look at. I know Medicare is always looking at, Department of Health is always looking at, and in line of being able to deliver that best care, which is our goal, we continue to drive to that. And I know, Dr. Raji, you'd mentioned that you want to really kick this one off, but before you get started with that, though, par for this show, why are you a doctor? Why a CMO?
I guess I started with philosophy in college, went to psychology, and that brought me into an interest in medicine. I had some other degrees along the way. My father was a NYPD police officer. I always had an interest in law. When my daughters were teenagers, I went to night school to get away from them a little bit, but to get my law degree. So I wanted to bring all the talent that I had and all the experience and quality, et cetera, to the senior leadership team as Chief Medical Officer.
Perfect. And then now you had indicated that you really had a passion for our topic today, and that you definitely wanted to give a quick lead in, and then we're going to introduce the rest of the guys here and really kind of kick into some discussion.
So I think the underlying theme is community wellness. Mm-hmm. We're talking about infection prevention today. When President Clinton was president, profits for the hospital were about 10%. Now there's pressures in medicine, high cost of labor and high cost of everything, pharmaceuticals, et cetera. Our profit margin is probably 1% to 2%. The Center for Medicare Services, which actually pays Medicare to hospitals and to physicians, have started a program called Pay for Performance. So they're looking to improve community wellness by decreasing hospital-acquired conditions and decreasing hospital-acquired infections also. So they do perform a clawback of some monetary funds if hospitals get a penalty. So it's not only for the community, but for improving the care that we can give the patients. You mentioned a Joint Commission coming recently. I must say I'm very proud that the Joint Commission noted that our AMS program, our Antimicrobial Stewardship program, is one of the best in the nations, and they gave us stellar accolades for that. And what this is most people know bacteria versus virus. Antibiotics can help eliminate a bacterial infection, whereas it won't do anything for a viral cold or flu. In fact, that's the genesis of antimicrobial stewardship. Everyone's worried about a superbug that can come out and give a pandemic or an epidemic of diseases. We have some in the news in the past decade. And every time we give an antibiotic, these bugs are really smart and they become resistant to the antibiotic. So we have to be judicious when we use it, and Daniel is going to talk about that a little bit more. So Ken is an infectious disease specialist. He's an epidemiologist. I can spell it. I can say it. But I'm going to let Ken explain it. But one of the things that Ken brought to the hospital, which I'm very happy, is something called the BETTER study from the CDC and Duke University. The benefits of enhanced terminal room cleaning decontamination, so that When you go into the hospital, a hospital is a great place to be for certain conditions, but you don't want to stay in the hospital too long. So when a patient leaves the hospital, we make sure that we clean it and we use it according to the CDC recommendation in the Better study. And by this, we use quaternary ammonium, which is a cleaner. It's not soap, it's a little stronger, and it will kill spores. And I'll go through that in a minute, combined with UVC, which is a certain bandwidth of ultraviolet light, which is very effective for something called C. difficile, which is a disease that is very difficult because if a patient has this and they're toxic, they leave spores behind, which are very resistant, but the quaternary ammonium compounds and UVC will be the most effective to doing that. So we have a program here, and we find a lot of benefits. Ken has pointed out to me that we've also decreased the multi-drug resistant organisms with this program of terminal room cleaning. So I just wanted to give that as an introduction before I introduce these experts here.
Absolutely. Thank you. I really, truly appreciate it. And obviously, this is a really, really big deal, that it isn't just housed within the four walls, so to speak, of the hospital, but actually extends out into the community. And, Dr. Raj, you said something very, very important, is that, the hospital is no place for healthy people. And ideally speaking, is as soon as you are safe enough and stable enough to be able to leave a hospital, that's really a great idea, because the exposure is common. And being able to get into an environment that you're more used to, something that is more used to you, like home, is such a great direction to go.
It'd be interesting for your listeners to Google Hospital of the Future. More and more medical care will be given as an outpatient, surgery centers, urgent center, telemedicine, and only the most sick patients, the ICU, the ER, the NICU, and surgical cases that need to be done in a hospital. So the hospital of the future is going to be a lot different than the one that we have today.
Absolutely, and it's going to be safer. Now, Ken, please, let's hear about your story, and then I'll have you tag team on what Dr. Raji was just talking about.
All right, so my name is Ken Archulay. I have the privilege of being the Infection Control and Epidemiology Manager for Holy Cross. And I've been there for 12 years, and it's been an exciting adventure. My background is in nursing. 16 years ago, in my nursing career, I took a turn to go into infection prevention. Infection prevention is generally a specialized nursing area, and but it's also involves a lot of training, specialized training, and we have professional organizations like Association for Professionals in Infection Control and Epidemiology. And I was fortunate enough to be in the Air Force at the time as a medical evac nurse, and received my training in the infection control from the Air Force as well. It's been a great ride. But the question is, what do infection preventionists do in the hospital? And infection preventionists use their detective skills to find the bad germs, basically, and make sure that everyone is doing the right things to keep our patients safe. And then our priority is of the IP that usually every hospital has an infection prevention department, is to ensure that healthcare workers are washing their hands. But not only that everybody's washing their hands. I can't emphasize that enough. That's an amazing struggle to ensure that happens, to also keep our patients, employees, and our visitors safe. That healthcare workers are getting the proper vaccinations. I know there's a lot of discussion about vaccines these days, about getting flu shots, your annual flu shot. I got sick when I got the flu shot. That's signs and symptoms of flu vaccine are very common. It's because your body's working to build up an immunity to the flu that's coming into play each year. And then we ensure that doctors and pharmacists are providing you with the appropriate antibiotics. And I'll let Daniel talk about that a little bit more, because he's really the expert in that area. he has an outstanding antimicrobial stewardship program in our hospital. And but the other things are catheters and dwelling devices. Most of the time when you come into the hospital, you're going to get a catheter or some type of indwelling device, and that's placed, and that you receive the proper cleaning, and that it's kept clean, and it's removed as soon as possible. That's a huge focus of infection prevention in the hospitals. And safe injection practices are followed all times. That our patients come in and that they're receiving the right vaccines. Often we have patients coming in the hospital that don't follow up on their vaccine regimens, the recommendations, whatever period in their lifetime. But it's very important that we assist with that and make sure that you're protected. Health workers are wearing gloves, and like Dr. Raji was talking about before, that the environment's kept clean and pristine, because let's face it, in hospitals, people are coming in sick, otherwise they wouldn't come into hospitals. And that's really the source of where these bugs come from.
Our cafeteria food is pretty good, though.
Yeah.
So, I mean, we don't want to slight that. So there are some people, in fact, the high schools will show up just to have lunch. So I just want to throw that in there.
We have an awesome food services department.
We really do.
And that your room and any equipment that's used in your room, that's kept clean. Again, that's it's really hard for the public in our community and healthcare to recognize, because these bugs are unseen, and that's our job, that's our work, to make sure that these organisms are killed, basically, and that you're receiving care. I mean, safe care.
Right, and then the hand washing, as you mentioned, that's such a big deal. And for everyone who's listening, one of probably the best way for infection control is simply just by washing your hands and staying active with that. In fact, as you are coming into medical facilities, when you're coming into hospitals, it's not they're there for a reason. But we have Purell dispensers at the front of all of our public entrances because we want you to Purell when you walk in. And Ken and I were kind of joking about it yesterday, but we kind of want you to use the Purell so that way we're not bringing outside gunk into the hospital. But then on the way out, make sure you wash your hands. Make sure you Purell on the way out, so that way you leave the hospital stuff in the hospital as well. So that way we don't have a lot of this cross contamination things going on. And if you're going to be ODC about something, what a great healthy thing to be able to do for yourself, as long as it doesn't completely mess up.
Yeah, we have a saying in infection control that if everybody, including patients, visitors, and staff, were washing their hands 100% of the time, we wouldn't be having this conversation.
Correct.
About infections.
That's
How long do you wash your hands for?
It depends. If soap and water, really soap and water is just really denuding your hands of what's on your hands. And you sing happy birthday, get a good foam going and rinse your hands off. But alcohol-based hand rub that's available throughout the facility actually does a kill on your hands because of the alcohol, and that's about 15 seconds till you feel that flash off your hands, and it's killed 99.9% of everything that's on your hands.
Which is perfect, and we see it everywhere. I mean, everyone's got it on their keychains. They've got a Purell dispenser or some form of a hand sanitizer. How many times should you apply a hand sanitizer before you actually should wash your hands? Frequently,
until your hands feel that you need to wash your hands with soap and water, especially if your hands are visibly soiled. But it's alcohol-based hand rub has emollients built into it, and that's what helps keep your hands from cracking and peeling and drying out. So.
Well, perfect. Well, we're just coming up on our commercial break right now. You're joining us here on the Providence Health Hour. Dr. Bob Raji, Ken Archuleta, and Daniel Salas joining here for discussions on infection prevention. We're going to take a small little break, and we'll be back shortly on your hometown station, KHTS.
Santa Clarita Philharmonic has begun its season of free concerts. The SCP is a non-profit community-based volunteer symphony orchestra comprised of local musicians from throughout the Santa Clarita Valley who are dedicated to providing quality classical music for the residents of the Santa Clarita Valley. Like the Santa Clarita Philharmonic on Facebook, or visit santaclaritaphilharmonic.org for more information.
Who says nothing good happens after midnight? Denny's is best known for their breakfast served round the clock, like the Grand Slam. But you can enjoy breakfast, lunch, or dinner in a casual atmosphere 24/7. At Denny's, the lunch and dinner menu has a variety of appetizers, craveable burgers, salads, and entrees, along with the best desserts in town. Wherever you live in Santa Clarita, there's a Denny's close by. If you're pulling an all-nighter or don't feel like cooking, get into Denny's today. Good stuff is happening at Denny's.
The Santa Clarita Artists Association has a new gallery in downtown Newhall on 6th Street between Main and Railroad, right across from the Canyon Theater Guild. The gallery features our members' paintings, sculptures, and one-of-a-kind handcrafted gift items. Whether you're an art lover, buyer, or an artist wishing to join, visit our website at santaclaritaartist.org, come to our free monthly meetings at Barnes & Noble, or stop by the gallery. For upcoming events and exhibits, check us out at santaclaritaartist.org. We make visual art visible.
Good morning, honey.
Oh.
What happened?
Trump, again.
Now what?
Our Congressman Steve Knight doesn't do anything to stand up to Trump.
Well, then we need someone new in Congress.
Definitely. The election's on June 5th.
So who are you going to vote for?
Brian Caforio, without a doubt. In that voter info guide we just got, he's the only Democrat who says he'll stand up to Trump.
Let me see that. Oh, Caforio's a Yale Law School grad, and he clerked for a United States federal judge on the Ninth Circuit Court of Appeals. With that experience, he'll definitely hold Trump accountable when he breaks the law.
And he'll stop Trump's attacks on our health care, the environment, immigrants, and Planned Parenthood.
Well, it's about time.
Caforio's supported by dozens of local officials, even Lieutenant Governor Gavin Newsom.
I'm sold. Brian Caforio on June 5th.
Yep, Brian Caforio for Congress. Oh, June 5th can't come fast enough.
I'm Brian Caforio, Democratic candidate for Congress, and I approve this message.
If you are at least 55 years of age and have a torn or irreparable rotator cuff, you may be eligible for a no-cost clinical trial at Southern California's Orthopedic Institute's Valencia Clinic. Call 818-901-6600 extension 1525 or visit rotatorcuffstudy.com to learn about a study of an investigational shoulder implant. Call 818-901-6600 extension 1525 or visit rotatorcuffstudy.com. Sponsored by Microair Surgical Instruments.
Our trash has got to go somewhere, and Chiquita Canyon Landfill is helping make the Santa Clarita Valley a little greener. Our local landfill creates clean energy from our waste disposal to power 10,000 homes each year. With their 9.2 megawatt clean energy facility harnessing the landfill's methane gas, you can feel good that the waste from your home in the SCV is helping create a clean energy source. Chiquita Canyon Landfill is our partner in sustainable living.
Chiquita Canyon is helping lead the way to a greener future.
Now FM, 98.1 FM, and AM 1220, your hometown station.
Doctor, give me the news. I've got a bad case of loving you. No pill's gonna kill my ear. I got a bad case of loving you.
And welcome back, Santa Clarita. We're here joining us on the Providence Holy Cross Health Hour on KHTS, your hometown station. Finding us here on 1220 AM as well as 98.1 FM, as well as on the app. I want to welcome you back again. I'm Tom Burton, your host, Orthopedic Program Manager at Holy Cross. Now you're going to see if you're watching us on Facebook Live, which you absolutely can, just to see, put a face behind the voices. Dr. Raj, he had to take off. Had some pretty big meetings he had to get back to over at Holy Cross. But Ken is with us still, as well as Daniel. And, you know, we just got finished discussing the importance of infection prevention and the things that we're doing at the hospital that will be very, very helpful. But, you know, there was a brief introduction to antimicrobial stewardship, which, you know, I got to be honest, when I saw the acronym come by, I'm thinking AMS. I'm just not seeing what that is. And, you know, really glad to be able to have you here. Daniel, now I understand you're a pharmacist.
Yeah, correct. So I could start with my background. So I went to pharmacy school in Stockton, California. In pharmacy school there was about 3 years, exactly year-round. And one of the semesters we had an entire course on infectious diseases. So that's sort of where I got my start and my interest in ID. After that course, it was a very difficult course, but I enjoyed it a lot, learning about the different antibiotics and how using antibiotics can cause resistance and, optimizing the dose of antibiotics to improve outcomes. All of that was very interesting to me. And so on my last year of pharmacy school, when I went on rotations, actually on site at a hospital, that's where I got like real life exposure. So during my last year of pharmacy school, I went down to the VA in San Diego, and I was fortunate enough to have an elective rotation specifically in infectious diseases. And I worked with a really great pharmacist who specializes in ID, and he was my mentor during that 6-week rotation. He showed me, a lot of interesting things. I got to see a lot of interesting cases at the VA of different, types of infections, and really that's where I got my first exposure to the pharmacist's role in taking care of patients with infectious diseases. Getting to see him work side by side with nurses, other physicians, seeing how he was a well-respected member of the team. Physicians would come to him and ask him questions, about should I use this antibiotic, what should I do next, etc. So he was just a really inspirational mentor to me, who kind of really kickstarted my interest even more in pursuing a career in infectious diseases.
And it's so funny, you mentioned it again. It's teamwork, the concept of everybody is involved, and that is something we actually do at the hospital as well, that everyone really is just a caregiver, and everyone's part of the same team, and including pharmacy, which carries actually an extremely important role, as we're finding more and more that, we could be very efficient in our care if we're using the right stuff.
Right, and so it's very important to have like a multidisciplinary approach to stewardship. And so after my experience there at the VA, I pursued residency training at the county hospital up in Oakland, California. Mm-hmm. There I got more exposure to different, ID-related cases, and worked with another great infectious disease pharmacist who also, again, showed me the important role that pharmacists could play. And so eventually after that, I knew for sure that I wanted a career in this. So I pursued a second residency specifically in infectious diseases, where I spent an entire year just focused on infectious disease, working with the ID physician, going on bedside rounds, and seeing a lot of complex cases. So this was at Huntington Hospital in Pasadena, California.
In Pasadena. So now if you're watching on Facebook Live, you realize that he must have started his education when he was about 4, which probably get him up to where he's almost illegally able to drink now. So kidding. So really, and just to gain a general level of appreciation that as a pharmacist, you're coming out with your doctorate in pharmaceutical, and that being said, you've gone above and beyond into further training, spending additional years in order to kind of perfect your trade, so to speak, right?
Right.
Which really does make you a resident expert. And now at Holy Cross.
Correct, yeah. So I joined Holy Cross after my residency, 2015. So I've been there for about 3 years. And my main role is functioning as the antimicrobial stewardship program manager / infectious disease pharmacist.
Now, can you explain stewardship? I know it's it was a core measure, a core value for us at the hospital, but it's not a very commonly used word. So
so stewardship in general has been defined by a couple different accrediting bodies, and the main gist of antimicrobial stewardship is optimizing antibiotic use, making sure antibiotics are being used appropriately. So whether that's the indication of the antibiotic, the dose of the antibiotic, the duration, etc., anything concerning the antibiotic and its use in patients to improve their care, optimizing its use is antibiotic stewardship. And so antibiotic stewardship programs aim through a variety of different strategies to try to achieve that, to try to optimize our antibiotic use. And so when I came on board, my main role was to take our stewardship program to the next level. We already had a stewardship program in place, but we didn't really have a pharmacist who was trained in infectious diseases. It was sort of operated by our different clinical pharmacists who would rotate through the shift, mm-hmm. and they would do their best to try to control antibiotic use, make sure it's being used appropriately. But when I came on board, we implemented a variety of different strategies to really hone in on that and make sure that we were using our antibiotics appropriately.
Very good. And now, do you have an example? I think that it would be interesting just to kind of hear how your role, maybe if we take like a pretend case that you might come across, that on how your role would have an effect on the direction of care and things like that?
Yeah, so on a patient-specific level, on a case-by-case level, I'm reviewing cases every day. And the way that I review patients in the hospital, so on average, if we have a census of about 250 to 300, and we estimate that 50% of these patients are all on antibiotics, it's going to be hard to review everybody. So I have to prioritize. So the first group of patients that I review are the patients with the very severe infections. So these are patients with bloodstream infections where the bacteria is actually inside the patient's blood. And so I can review a list through our electronic medical record that actually is a very useful tool. It pulls all the patients who have a blood culture that's positive for some sort of bacteria. And so I can review these cases and see, okay, are these patients on the right antibiotics? And if not, what needs to be done to get them on the right antibiotics? And so there's been a couple cases, it always happens where a patient will have, a positive blood culture and not be on any antibiotics. And so the first thing I do is review the case and say, okay, this is what's going on with the patient. These are their labs, and this is what needs to be done. And I can go ahead and page the physician in real time and get these patients started on the right antibiotics to improve their care.
Which is great. So basically, we can intervene more immediately.
Right.
The patient is going to get better sooner,
right,
and quicker.
Yeah, and rather than having the general hospitalists who they do their jobs well, but they don't have necessarily the background in antibiotics and know what is the best antibiotic for this particular situation. So, for example, patients who come in with a very simple urinary tract infection. With a E. coli that's your run-of-the-mill E. coli, very sensitive to a variety of different antibiotics. Sometimes physicians will like to use the shotgun approach, where they basically use a shotgun to kill, the bug, whereas in reality, the best antibiotic would be the sniper rifle,
right,
where it doesn't cause so much collateral damage and kills the exact specific bug that's in the urine.
Right.
And so a lot of times that's what I do is try to help the physicians and guide them into using the sniper rifle, the more narrow spectrum antibiotic that will do the best job of killing
that specific organism. And then
right.
and then I guess that would probably set the tone that if you're using something that's more broad spectrum, that that can be maybe one step into how we start running to resistance.
Right. So looking at a more global perspective as opposed to a case-by-case, but for the overall hospital, one of the major drivers of resistance, obviously, is antibiotic use, and namely inappropriate antibiotic use. So when I first came to Holy Cross, there was one antibiotic in particular that a lot of the physicians had gotten used to using, a drug called meropenem. So meropenem is among a class of antibiotics called the carbapenems. Traditionally, you learn in school that the carbapenems are the agents of last resort. These are the drugs that are very broad spectrum and will pretty much kill any bug that you could think of that can cause an infection. So very broad spectrum, very much an agent of last resort.
Right.
Over time, after the drug got released around the late 1990s, physicians started becoming more comfortable with meropenem, started using it a lot more, and actually started using it as their frontline agent. When you don't know what's going on with the patient, just give them meropenem, it'll cover everything, they'll get better.
Right.
The problem with that is you get resistance to meropenem. And what happens when you get resistance to what we commonly refer to as an agent of last resort? There's nothing left to treat the patient. And you may have heard about these infections on the news, outbreaks at UCLA or even Huntington Hospital where I did my training. Patients were getting infected with bugs that were resistant to the carbapenem class. And so when they're resistant, there really is not much left to treat these patients. We end up having to resort to old school drugs, things like colistin, drugs we were using in the early 1980s that are very toxic and not necessarily the best for the patient.
So not the best thing that came out of the 80s is what you're saying.
Yeah. And so my role coming into this position at Holy Cross was to try to optimize our meropenem use. We were using it, like water. Everybody was getting it. And we had to try to figure out a strategy to try to cut back. And so one of the strategies that we did was implement a controlled formulary criteria. So for the listeners that aren't really familiar, a formulary is a list, of medications that the hospital uses. So we have an antibiotic formulary, the different antibiotics that Holy Cross carries within the pharmacy. Now our controlled formulary was tapering this list down even further and saying these specific antibiotics are going to be used for these specific indications only. And so if you're going to prescribe it for your patient, you better make sure that the patient meets the criteria.
Right.
And so that's what we did. We implemented a criteria to ensure that meropenem was being used appropriately. And really the criteria just boils down to patients who are severely ill and are very high risk for multi-drug resistant infections. So patients who are coming from a skilled nursing facility, who have been in the hospital for a long time, had received multiple courses of other antibiotics. Those are the patients who we're targeting. And then also on top of that, patients where we have the culture results and the culture show this bug is very resistant and meropenem is the only drug left to treat it.
Gotcha.
And that would be considered appropriate.
Okay, so it's amazing to be able to actually listen to this, and it's something that, years and years back when we used to do a lot of our wound care, there was an awful lot of broad-spectrum antibiotics being used back in the early 90s, back when we were doing it down in physical therapy. And it certainly stands to reason that, by simply culturing the wound, just to get an idea, now it may not be the best measure, but at least to get an idea of what bug might be there, that they, in the broad spectrum where you may get improvement, but it's slower improvement, like you said, you might be able to have a much more poignant effect on something if you're being more specific.
Right.
And it was a very big deal for us during wound care during those times, and hugely important at the hospital. And I can only imagine now between the two of you, it's funny if everyone's listening really got a feel of this, that we have an environment that we need to keep clean. And we have our patients that we need to clean, so to speak. And the combination of the two of those is where we're really going to find our community health. It's what it sounds like. Ken, does that sound about right?
Oh, I'm just, I was just thinking too, that part of that conversation that you mentioned teamwork earlier. And I'm just really grateful that Daniel's part of that team at Holy Cross because, as part of the investigation, a daily surveillance that we do, we look at all of the microbiology every day of positive cultures for our community, our patients that are in the hospital. And it's a huge undertaking trying to make sure that they're all kept safe and put into, we have something called standard precautions. And standard precautions is practiced by all healthcare providers in the hospital. And if we identify a resistant organism, which they call MDROs, multi-drug resistant organisms, that we put them in the appropriate precautions. And then we teach our patients and their families that this is the reason why we're taking these actions, to protect them and the rest of the hospital, the community. So, but oftentimes I'll get a call from Daniel, and he'll say, this, did you catch this one? This one's a little bit more riskier multi-drug resistant organism, and it's the reason why I say I'm grateful is because there's only so much you can capture and that's the team effort. Is wow, that's great. Thank you for the heads up, and that we can appropriately isolate these patients and protect our.
And you really you said something so important too, is that, and it's something that's been emphasized as we've talked on all of our shows. The family is a really big, important portion of that team. And, being able to educate the family, protect the family, has been, so helpful with all of the patients that we see. And it seems to be a very common thread. We're going to do great patient care. Oftentimes, the patient isn't the one we actually have to be caring for. A lot of times, we actually really have to care for the families as well. And being able to bring all of the information on how, those patients are going to go home, and they're not going to have a kin who's going to assist in making sure that the home environment is safe. So I can imagine that's a great opportunity to be able to talk with the patients on how to better prepare the house and how to keep the house, perhaps, and things like that. And not only that, but also the recognition that everyone who gets sick seems to say the same thing. I just need to get an antibiotic. But as Dr. Raji said, maybe it's a virus, and the antibiotics isn't going to touch that. But we do see where the first line of defense on anyone who comes in who's got congestion, things like that, for a long time, they were just being given the Z-Pack, and here, listen, this is the magic drug, and this is what's going to take care of it. And we're finding more and more it's not going to be helpful, and in certain cases can be harmful.
Right, yeah, and the CDC actually touches on that. They released a document a couple years back called the CDC Core Elements of Antibiotic Stewardship. And one of those core elements is patient education. A lot of the times if antibiotics are prescribed inappropriately, sometimes it's not because the physician doesn't know better, but because he's pressured by his patient saying, oh, I'm sick, doc, just give me antibiotics. And, well, I don't think you necessarily need it. Well, I would feel better if you gave me antibiotics. And so sometimes we're getting a lot of pressure from patients themselves who say they want antibiotics. And really it comes down to a matter of educating patients and saying, hey, well, these are the symptoms that are consistent with a viral infection. And viral infections will not get better if we give you antibiotics. And as we've talked about earlier, there's a lot of side effects to antibiotics, not just antibiotic resistance, which could be detrimental, but infections like C. difficile, which is caused by antibiotics.
Yeah, and it's so funny. I know we have about a minute or so before we have to go to break, but it's amazing to know that the antibiotics, and as we find, gut health is becoming a much more important thing, and more important than I think that anyone really would ever shake a stick at. And that with the chronic use of the antibiotics is that we are actually messing up our own flora and fauna if it's not necessary. And that flora and fauna not only assists with just normal digestion, but it actually has a huge effect on our overall general health. And trying to rectify that can be quite the challenge, it seems like.
Yeah, antibiotics play a huge role in disrupting your normal gut flora, and this is something that we have since childbirth. We acquire these organisms in our gut, and they help with a lot of things, like not just digestion, but overall health, as you alluded to earlier. Well, and giving antibiotics could just completely destroy that.
Right. So, okay. So I know we have a few more minutes to be able to finish this discussion. We have to go.
Daily Imprints is the premier one-stop shop for custom embroidery, screen printing, and promotional products in the Santa Clarita Valley. Owners Joe and Dana have provided KHTS with quality embroidered company shirts for over 3 years. If it's new business cards or promotional products you need to enhance your image, Daily Imprints is the choice for you. Located on Lyons Avenue, stop by or call today, 661-678-0508.
Your building sign is essential in getting customers to your location. Feathers can help get your business noticed. They walk you through each phase of your building sign project, providing special attention to detail and quality. Feathers will give you a sign you can be proud of. Your building sign will draw customers in instead of having them drive by. Feathers on Soledad in Canyon Country, across from the Edwards Theater. Or go to feathersphoto.com. That's feathersphoto.com.
Every day after school, children and teens in our community are alone without academic support, access to healthy food and activities, or adults to guide them. With your support, we can provide our youth a second home, support their academic success, and build leaders. Join us Saturday, June 2nd at All That Glitters is Gold, the Boys and Girls Club of Santa Clarita Valley's annual benefit auction. Visit scvbgc.org or call us at 661-254-CLUB to purchase your tickets.
Men, are you feeling tired, stressed, or just don't have the energy you used to? Did you know this could be related to decreased testosterone levels? Luckily, there's a safe, effective solution. Weeder Prime helps support healthy testosterone levels with clinically tested key ingredients. Just 2 capsules of Weeder Prime each day can help change your mood, energy, focus, body fat, and lean muscle. Feel the way you felt 10, 20, even 30 years ago. Rediscover your Prime with Weeder Prime. To find a retailer near you, visit WeederPrime.com. That's WEIDER Prime.com.
At Advanced Audiology, we know how important hearing is to you, your loved ones, your work success, your safety, and your ability to stay in the game. Most people won't admit hearing loss to themselves or others. We make it easy for you. Today's digital hearing aids come in a variety of styles, including invisible. All feature-rich, providing unparalleled hearing quality, wearing comfort, and automation that simplifies your life. Don't be fooled by our imitators. There's only one Advanced Audiology with the purple sign next to AAA on Valencia Boulevard.
I love it.
Right on!
Your hometown station.
Doctor, give me the news. I've got a bad case of loving you. No pill's gonna kill my ear. I got a bad case of love.
And And welcome back, Santa Clarita. You're joining us here on the Providence Holy Cross Health Hour. We've just got finished. Gosh, this really has flown by. We're talking about infection prevention, antimicrobial stewardship. We've got our wizards from Holy Cross, Ken Archulay and Daniel Salas, and we just got finished talking about, how wonderful antibiotics can be when used very specifically to treat specific bacterium that will allow us to get better. However, the cost can actually affect our flora and fauna within our GI system, which can cause its own problems. During the break, I don't know if you're watching on Facebook Live, you kind of saw us. We're not actually just having a conversation about sports. We're actually talking about a few things. But how important is the electronic medical record, and for the ability for us to be able to do what we do?
So for me, it's huge, not only for identifying the patients that we want to make interventions on, but also collecting data and making sure that we're doing the right thing and seeing the outcomes that we want. So one of the Joint Commission, regulations is to actually show data that your stewardship program is working. And the only way to do that is through our electronic medical record.
Right.
So one of the metrics that we look at to measure the success of our program is overall antibiotic consumption. How much are we using? And so one of the metrics that we use is called the antibiotic days of therapy per 1,000 patient days. And this is a standardized metric that's used across pretty much every hospital across the world. It's becoming the standard measure of antibiotic use, is the antibiotic days of therapy. And so one of the things that we did was measure our days of therapy before and after implementing certain strategies. So the drug I mentioned earlier, meropenem, that very broad spectrum antibiotic. Before we started our strategy to make it a controlled formulary antibiotic and really optimize its use, our days of therapy per 1,000 patient days was up in the hundreds. And that was in Q3 of 2015, or prior to that. And then in Q3 of 2015 was when we implemented our strategy. And subsequently, each quarter after that, it dropped and dropped and dropped. And so now we're averaging days of therapy of about 30, which is a significant reduction in meropenem. And so not only are we getting a cost savings from just overall meropenem use reduction, that's a cost benefit to the pharmacy. We're saving money there. But I think the bigger impact is that environmental selection pressure of having much less meropenem out in the hospital, out in the environment, out disrupting your gut microbiome, because that's where resistance develops, is inside the gut. And so by using less meropenem, we're going to see less and less of these carbapenem-resistant infections that you hear about on the news. And that's really the major benefit, because once you can prevent those infections, then, patients' hospital length of stay goes down. Just everything, every downstream effect of minimizing resistance improves. And so, having the electronic medical record to demonstrate these improvement in outcomes is crucial.
And, the data collection, it seems that we always seem to come up to that when it comes to the conversations when we're doing the show, that, trying to do what we're able to do on an electronic medical record back in the days of a paper chart, you would have to review 300 cases to determine who your top 50 are. And that is a lot of paper to have to go through, where else now, because of the computer, we can actually sift through it by poking, just pushing an enter button, and one click away, all of a sudden that list comes up. And I know, Ken, with your work, you're keeping an eye on this, because the data collection allowed us to improve with our county stuff.
Yeah, it's amazing. We used to keep line lists of patients that came into our hospital that we identified multi-drug resistant organisms, not just for patient safety, but how to isolate these patients, or if you have to isolate these patients. And now the electronic medical record, it's part of their banner information. And most importantly, it's when the patients are coming back, it's a cue for the caregiver is, do we need to isolate these patients or not isolate them? But also for the provider, that they can identify that right away. Oh, they're coming in for a UTI. This person's been here previously with a multi-drug resistant organism causing that UTI. Then it's more effective therapy for the physician, and it gives them direction and what might I treat this with. And of course, with Daniel backing him up. It's what the most appropriate antibiotic, if it's necessary.
Right, and then Daniel, briefly you had mentioned that it's also extremely helpful with the electronic medical. We can actually see all the things that they have taken in the past as they've been within our facilities, so that way we can kind of avoid issues that way too, right?
Yeah, so when I'm reviewing patients, if they've been to the hospital before, it's all in the electronic medical record. So I can see what happened on their last admission, which is very, very helpful for patients who come in for recurrent infections. I can go back and look at the culture results and see, what was the organism that grew out in the past? Was it a resistant organism? Mm-hmm. If it was, is it covered by the current antibiotic they're on? And sometimes, I'll see patients come back and they're on the wrong antibiotic based on what they grew out on the previous culture. And then sure enough, they culture them again during this hospital admission, and they grow the same resistant organism, and you have to use, a better antibiotic to cover it.
Well put. And then, Ken, during the break, you had said something that it seemed very poetic, and I wanted you to maybe share that just before we wrap up.
Yeah, it's just that this opportunity to, one of our biggest focuses is the health of our community, and having this opportunity to step towards our new great adventure is to educate our community, and it's related to infection control and antimicrobial stewardship. So they need to know. We want to be transparent. We want them to be more well-educated when they come in the hospital to ask about these questions. Is my room being cleaned? Are these the right antibiotics that I'm supposed to be on? And perfect. This is a great opportunity.
Well, Ken, thank you. Daniel, thank you. Dr. Raji, you're on the road right now. Thank you very much. Thank you for joining us, KHTS. Thank you for allowing us the opportunity to be here. You've joined us here on the Providence Holy Cross Health Hour. I'm Tom Burton. We will catch up with you next month.